Hello, my name is Dr. Catherine Yashar, and I'm a radiation oncologist at the University of California, San Diego. I'm also the chief of the Gynecologic and Breast Radiation Services here, and we're here as part of October and Breast Cancer Awareness Month to talk about breast cancer and specifically Rethink Pink. We think of pink as awareness of breast cancer, but Rethink Pink means going from awareness of needing to be screened and that women are at risk for breast cancer, as are men, but much less commonly, to actually progressing to knowledge about breast cancer. Because when a woman is diagnosed with breast cancer, all sorts of decisions need to be made, and it's at a time of duress and a time of nervousness about what the future brings. So having some knowledge about the choices that you need to make ahead of time empowers women to make the right choice for themselves and the right choice for their family. So to submit a question, during today's program, you just type in your questions in the space provided below the screen. Those will then come to me, and at the end of the broadcast, I can go over those questions. So, what we need to know. What do you need to know after you're diagnosed with breast cancer? Most women know that they need to talk about a mastectomy versus a lumpectomy, whether or not they're going to get chemotherapy, whether or not they're going to get hormonal manipulation like tamoxifen or an aromatase inhibitor, and whether or not they're going to get radiation. But what they don't know is that there are actually many choices amongst all of those. For instance, during radiation, you may have post-mastectomy radiation, or if you just have a lumpectomy, you can have 6 weeks of radiation, 3 weeks of radiation, sometimes 5 days of radiation, or sometimes just 1 day of radiation. And knowing that those options are available to you and being able to phrase those questions to your doctor will make you feel more confident and more empowered to make the right choice. So there is a consortium of companies that is trying to teach women, to move them from awareness to knowledge so that they feel empowered to make these decisions. And it's called BC5. Their website is www.bc5project.com. Again, that's www.bc5project.com. And it has a question and answer area. It has experts' opinions on different topics. So it's a good website to check out. You need to be prepared for these decisions before you go, and hopefully even before you're diagnosed or before your friend is diagnosed, so you can be an advocate for her and help her make those decisions. So I'm going to tell you about a couple of studies. Dr. Huang, who is at the University of California, San Francisco, looked at the rate of mastectomies, and we found that the rate of mastectomies is actually going up. The history that you may not be aware of is historically all women, no matter how small their tumor was, had mastectomies. And it actually took a very brave surgeon and a lot of brave researchers to move beyond giving everybody a mastectomy and allow women to keep their breasts. Now we're seeing a rise in the rate of mastectomies again, which is quite puzzling. We've discovered that it may just be fear or misinformation. You've heard of a mammogram. Everyone gets a screening mammogram. An MRI is a wonderful diagnostic tool for women that need it. But one of the downsides of an MRI is sometimes it shows things as positive that actually aren't cancer. And so it's led sometimes to more biopsies, more anxiety, and in some cases, fear, which has led to mastectomies. She also did another study looking at 112,000 women that were treated between 1990 and 2004. The women ranged in age from 39 to 80, and it looked at the overall survival, the disease-specific survival. What does that mean? That means disease and survival just related to breast cancer, comparing a mastectomy with breast conservation therapy. So what do I mean by breast conservation therapy? That means that just the tumor is removed. Sometimes you'll hear that called a lumpectomy. So a lumpectomy and breast conservation therapy. And what she found was the survival was actually better with breast conserving therapy. In fact, there was a 13% decrease in death and a 19% decrease in death from any cause, both 13% from breast cancer and 19% from any cause. Now, there are some questions with this study, meaning that we don't women that had a mastectomy were already older and sicker, and that might have accounted for the difference in survival. But that and other studies would certainly suggest that the survival from breast cancer is the same whether or not a woman chooses mastectomy or a lumpectomy or breast conservation therapy. So it's not an advantage to lose your breast if you don't choose to do so, or your physician doesn't feel like it's best for you. There are some situations where a mastectomy is recommended, say if the tumor invades the chest wall or the size of the tumor relative to the breast, there may be cosmetic indications for a mastectomy. But again, that's a decision that you can make with your physician or with your surgeon. We do know now that more treatment does not necessarily mean better treatment, and that also goes for chemotherapy in some situations and radiation therapy in some situations. We've also found that younger women with smaller tumors are more likely to have mastectomies, and that's a research question that we're investigating. So why do women make these decisions? Who helps them make these decisions? Well, the BC5 again did a survey and tried to answer those questions, and what they found was most women get their information from the doctor that made the diagnosis. So is that a primary care physician, an obstetrician gynecologist, or is that the medical oncologist, surgical oncologist, or radiation oncologist who are experts in breast care? So if you're diagnosed with a breast cancer, it's very important that you get your information from people that are experts and do this all the time. Often I have patients come in and say, the anesthesiologist next door told me I should do X. It doesn't mean that you shouldn't listen to friends and professionals around you, but you need to balance that with the expert advice from the oncologist who you will be sent to by your primary care physician. So what factors drive decisions? How do women make these decisions? Well, 76% went on a doctor's recommendation, but they also wanted to factor in how does it affect their quality of life? What are the side effects and how will that affect my long-term quality of life? What is the impact on my family and my situation at home? All of these are really important things to think about, both when choosing the surgery, the type of systemic therapy. What that means is treatment, whether it's chemotherapy or hormonal therapy that's going to go all over the systems, all over the body, and radiation therapy. BC5 also asked these women, and women were generally over 50, there was about 100 women in the study, do you feel well informed about your choices? And I must say 78% of women felt well informed, which is great, even though that might have been the first time they heard some of these choices. 2/3 felt that they were given more than one option, that they had choices. Sometimes that's very empowering to women to know that they have a say and they have a choice. Sometimes that can be overwhelming for women that just want to be told what to do because they're scared. Only 7% had actually heard about one of the radiation options, and that's that 5-day option or partial breast radiation. In general, historically, when we moved from mastectomy to that breast conservation therapy, we've treated the entire breast. And to do that, sometimes we get other normal tissues like the edge of the lung, very close to the heart, even though in 2014 we can often exclude the heart. The ribs of the chest wall. Well, partial breast radiation therapy in women that are eligible for it just treats the tissue most at risk to have a recurrence of cancer. Where is that tissue? That tissue is sitting right around where the original tumor is. And partial breast radiation therapy allows that tissue most at risk to be treated, but spares normal tissues that don't need to be treated, like other parts of the breast and other organs that just get radiated by accident, like the ribs or the edge of the lung. So some women are eligible for this, but it's not as widely known as whole breast radiation therapy, which has been the standard for many decades. What about misinformation? How do women get misinformation? What kinds of misinformation do they get? One of the things that I hear quite commonly is women say, how did I get breast cancer? Nobody in my family has breast cancer, and they don't realize that only 10 to 15% of breast cancers are related to a known genetic factor. That means the other 85% of us got breast cancer because we're women. So the greatest risk factor for getting breast cancer is being a woman. But a breast cancer does not mean, in many, many women, that it's a fatal diagnosis that's going to shorten your life or even really negatively affect your quality of life. Sadly, in some women it does, but knowing your choices, going to your doctor, having a real dialogue can reassure many women that this is just another phase in their life that they can move beyond and still have a good quality of life. So what do you need to know? Well, just like shoes, one size doesn't fit all of us. We all get to choose the therapy that is right for us after empowering ourselves with knowledge seeking advice from the professionals, and having a dialogue. It's very important to have a dialogue with your doctor. Often you want to take a friend with you, only because when you're under duress, when you're anxious, it's very hard to hear everything that's said, to absorb everything that's said. Have you ever walked out of a doctor's office and think, I'm not really sure what that doctor said? Well, having either a tape recorder or a friend with you that you can talk about it immediately is very, very important. Educate yourself. Educate yourself now, even if you haven't been diagnosed with breast cancer, because then you can be a resource for friends and neighbors and a support system. It's your decision. Know that ultimately it's your decision. Even whether or not you want to be treated is your decision. Now, that may not be the right decision or the decision that we would agree with as medical professionals, but ultimately you are a thinking adult and it's your decision. And consider getting a second opinion. If you feel like you have read and you know what your options are, but the doctor that you see doesn't offer you all the options, then it's perfectly acceptable to get a second opinion. And there are many doctors in most cities that are happy. And most doctors who are giving an opinion should not be offended if you want a second opinion, because they want you to go where you feel the most comfortable and you're feeling like you get the best care. Why may they not give you all the options? Well, they may not offer all of those at that particular hospital, or they might not feel comfortable with all of the options. You may not be a candidate for many options, and all of those things they should be able to discuss with you openly and honestly. So that ends the basically presentation part of this. So I do have questions that have in, and just to remind you, if you think of a question, you can write it in that area below your screen and it will get submitted to me and we will go over that question. So the first question, is there anything a woman with early stage breast cancer can do to avoid recurrence? Yes. Sometimes it's chemotherapy, sometimes it's hormonal therapy, sometimes it's radiation therapy, and many times it's all three. Your doctor should help you make the decision, even to the point where they say chemotherapy may give you a 1% advantage. Maybe it's not worth the risk. Radiation, again, may give you a 20% decrease in your risk of recurrence, or it may only give you a 1% decrease in your risk of recurrence. It's not the same for every woman, and that's why knowing what the options are and then being able to fit that to your personal situation is so important. This is from California. What question should I ask my doctor to help me decide between a lumpectomy and radiation and a mastectomy? Well, we've already reviewed some of those. We know that in most patients, it doesn't change the survival, but there may be reasons why your doctor thinks that a mastectomy is a better option for you. Say the tumor relative to the breast size is so big that you would have a bad cosmetic outcome with a lumpectomy. But for the vast majority of women, there's no survival advantage to mastectomy, and you should be allowed to keep your breast. Also from Weldon, California, my mother has been given the option of radiation and a lumpectomy versus mastectomy. Any statistics about survival that would impact this decision? Yes. For most women, there is no difference in breast cancer survival whether you choose a mastectomy or to keep your breast. There was a recent study that suggested that perhaps the survival is better when you have breast conservation therapy, but there are other studies that say that it's equivalent. There's certainly not any studies that suggest that keeping your breast is going to give you an inferior survival or less chance of being cured for breast cancer. This one is from Atlanta, Georgia. Does my low Oncotype DX score mean I should do a lumpectomy, breast conservation therapy, and no radiation? Well, if you haven't heard of the Oncotype DX score, it's a score that's used often to help a woman decide whether or not to have chemotherapy. It has been looked at for non-invasive cancer, and it may help us decide the risk of recurrence in non-invasive cancer. That's DCIS, or ductal carcinoma in situ. But at this time in 2014, we don't have enough data to allow the Oncotype DX to help us make radiation therapy decisions. So at this time, it is not standard of care to use the Oncotype DX for invasive breast cancer. Hopefully with more research and more information, it will guide us toward the right answer for the right patient, but at this time, that's not considered standard. So again, from San Mateo, California, my mother had a lumpectomy earlier this week and has been offered 6 weeks of radiation. But I've been reading about shorter durations. Are there different radiation options? Absolutely. 6 weeks of radiation would be 5 weeks of radiation to the whole breast, followed by what's called a boost. A boost is extra dose right to where the tumor used to be. So that's a total of 6 weeks of radiation. There are now 3 studies, 2 from the United Kingdom and 1 from Canada, where women have been followed for 10 years, which is a long time, where they were randomly assigned to the standard 5 to 6 weeks of radiation versus 3 weeks of radiation, so 16 treatments, 15 to 20 depending on the study. And what those studies showed was the control rate of the cancer was the same. The effects under treatment were the same, although the timing may be a bit different, and the long-term effects on the breast were the same. In addition, there are also studies looking at partial breast irradiation, which we talked about before, where you may be able to have your radiation done in a much shorter time, a week or less, where just that part of the breast is at risk. The randomized trial, the trial where women were randomly assigned to whole breast versus partial breast, is closed, and we await the answer. But we do know that there are already some low-risk women who are eligible for this type of therapy and have been very happy with this type of therapy. So as you can see, there are many different options for radiation therapy, and having some idea what those options are before you go to the doctor gives you an advantage, empowers you to be able to make a wise decision. Are side effects for shorter duration radiation the same as for 6 weeks? The timing is different. It seems that the worst radiation side effects happen at about the 5th to 6th week, whether we're already done with the radiation or you're still undergoing radiation. And your radiation oncologist or your doctor will talk to you about that. But how much of a radiation burn you might get appears to be equivalent between the two. As in partial breast radiation, you can still get some redness of the skin, or radiation dermatitis is the technical word for it, but it tends to be limited to just where we did the radiation rather the entire breast. Okay, another question from Longmont, Colorado. Do you have an option on the real pluses and minuses of having 6 weeks of daily radiation versus 1 to 2 weeks of 2 shots of radiation a day? Yes, we do. And that is something that it's your physician's job to review with you. You know, let's say one of the minuses between 6 weeks of radiation and perhaps the twice a day is when you have a device placed in your breast, you might be at a little bit elevated risk for an infection. But the trade-off is shorter duration, less normal tissue radiation, and a more efficient treatment. So your doctor should be able to go through those pluses and minuses with you and help guide you towards the right decision for you. California, is brachytherapy the same thing as Mammocyte? Yes. Mammocyte is a type of brachytherapy. Brachytherapy, or brachytherapy, some people say, is when a device or a radiation seed is placed inside the body and radiates from the inside out, rather than a machine that brings radiation from outside the body. So, for example, a chest x-ray machine, the radiation is actually pointed at the chest and it comes from outside the body through the body and develops the plate behind the body. External radiation, or teletherapy it's sometimes called, actually takes the radiation and shoots it at the breast. Brachytherapy, Mammocyte being one of the carriers, the Mammocyte or the Savvy or the Contura are actually placed inside where the tumor used to be. So it's called a tumor bed. So the surgeon takes the breast, removes the tumor, and that leaves a hole in the breast. Those devices are placed in that hole, and then a radiation seed is placed in the device and radiates from the inside out. And again, only that 1 centimeter of tissue that's most at risk. There are other ways to do brachytherapy. You can also place different catheters inside the breast, but that's the most common way. This is actually a model, if you can see it. This is the device actually coming outside a model of the breast. And if I turn this around, you can see that this is a device sitting inside the breast. Now, this is the strut-based device, but there are also balloon-based devices that deliver brachytherapy or internal radiation. Next question from Southern California. Is it true that brachytherapy will expose less of my body to radiation than standard radiation? I am trying to make sure that it will be as good an option as 6 weeks of radiation with less radiation. So the dose to the tumor or residual tumor, as it were, because you've had a lumpectomy by now, is equivalent. But the dose to parts of the normal tissue are very different when we just treat part of the breast or the whole breast. Other questions from Westport, Connecticut. So now back to the East Coast. I'm terrified about radiation treatment. Is there any advice to prepare me for this? I have a long drive every day and I'm really worried about being able to do this alone. Well, the nice thing about radiation therapy is it doesn't make you nauseated. It doesn't impair your ability to drink and shouldn't impair your ability to drive. So you should be able to drive yourself back and forth to your appointments. But if it makes you feel more comfortable to have a support system, have a friend with you, by all means, bring your friend with you. They can go with you right up to the point where you get your radiation. But when you get your radiation, you get to do that yourself. But the radiation oncologist and the trained therapists can see you and hear you at all times, so you're never actually alone. Oh, one more part. Any advice to prepare me for this? Educate yourself. If you go online, University of California, San Diego is where I work, and we have pictures of what the machines look like, pictures of what the planning scanner looks like, so you can read about that online before you even go to your doctor's office. And many cancer centers on their website have educational materials for their patients. The BC5 website has educational materials, and there's sometimes even classes. We offer a class to patients that are scheduling radiation so they can actually walk in and see a machine, walk in and see the planning machine, so it's not so intimidating when they actually come for their first treatment. Okay, from Chicago, Illinois, the Midwest now. I will be starting radiation therapy in 3 to 4 weeks. What can I do to prepare myself for this? Educate yourself. Empower yourself to make the right decision and decrease your fear and anxiety that comes from just not knowing what's going to happen, which is a normal reason to be anxious. McCordsville, Indiana. One of my surgeons recommended mastectomy and the other recommended lumpectomy and radiation. Do you have a recommendation depending on the outcome of my genetic testing results? So there are many kinds of genes that we test with cancer. The most common for breast cancer is BRCA, or some people call it the BRCA gene. This is the one that you've heard about with Angelina Jolie. It puts people at increased risk for breast cancer and sometimes other cancers like ovarian cancer. For women that are BRCA positive, which is a very small proportion of the women that are at risk for breast cancer, sometimes having a mastectomy can decrease the risk of breast cancer or sometimes even improve your survival. So there are some genetic tests where a mastectomy would be offered. It doesn't mean that you have to get a mastectomy, but they would lead you through those options. Again, a woman who's less than 40 might be encouraged to do bilateral mastectomies more than a woman who is, say, 60 when she gets her diagnosis of BRCA. There are other genetic syndromes like P53, and that one in particular is not important, other than we know if you have a P53 mutation, mastectomy might not necessarily be the right option, but it might, because those patients might want to avoid radiation. So your doctors and your geneticists will walk you through those options and help you make the right decision. New York City. Should genetic testing affect my decision to have breast-sparing procedures? Again, it depends on the genetic defect, and if you have a genetic defect, whether or not you should have a breast-sparing procedure. Westbury, New York. Does the type of radiation therapy I choose affect my reconstruction options? Yes. If you have a mastectomy, post-mastectomy radiation will affect your treatment options. Sometimes you have an implant or an expander placed at the time of surgery, then you have post-mastectomy radiation, and then it's traded out for your final implant. Sometimes your final implant is put in at the very beginning, and the final implant is given radiation along with the chest wall. Now, not purposefully, but because it happens to be right there. But if you don't have an expander or a final implant put in before your radiation, then often the best option for you is to have tissue moved elsewhere in your body onto your breast and have that kind of reconstruction. Your plastic surgeon and your breast cancer surgeon will help you with those decisions, as will your radiation oncologist. New York, do you suggest doing implants before or after radiation? You know what? We have a session on that at our national meeting every year. It's done different ways in different parts of the country and different hospitals. I must say I've done it both ways depending on the surgeon that I work with, and I am happy with it both ways. I don't clearly see a large difference. The only thing you want to make sure is that your reconstruction does not delay your cancer therapy. So it's really important that your doctors work together, your radiation oncologist, your surgeons, your medical oncologists, so that you do a stepwise progression through the needed treatments without unnecessary delay. Because we all want to have a good cosmetic outcome, and we want to feel good about ourselves, we want to feel good about our bodies, but we certainly don't want to delay our cancer therapy for those kinds of considerations. Nashville, Tennessee. Is radiation necessary following a mastectomy for breast cancer? Not always. Some women can have a mastectomy and need no further therapy like radiation, but some women, if they have certain risk factors, will have a recommendation for radiation, and that depends on what is found at the time of surgery. Brick, New Jersey. I just started radiation and my breast is so sore. I can't stand having even my sheet touch it. My doctor said that I shouldn't be having any effects from radiation this early in the treatment. Again, she just started. Is this normal? Well, there's a range of what's considered normal. Most women don't start having side effects from radiation until about 3 weeks into the radiation, but many women do. And so your radiation oncologist should work with you to try to minimize those symptoms whenever you start to have them. Something that would involve creams or dressings or maybe pain medicines, which could include something as simple as Tylenol or ibuprofen, but may need stronger pain medicine. And again, it depends on the individual situation. St. Petersburg, Florida. If I get a lumpectomy, do I get to keep my lymph nodes? Well, in most breast cancers, we need to at least sample a lymph node or two. That's called a sentinel lymph node biopsy, meaning they find when the breast cancer is draining to the lymph nodes, they find the 1 to 3 or 4 lymph nodes that are the first echelon, it's called, basically the guards of the gate. And they look at those lymph nodes, and if those lymph nodes don't have cancer in them, that it's unlikely to have cancer in your other lymph nodes, and you can avoid having all of the lymph nodes in the axilla, or a full axillary dissection, it's called. If you have 1 or 2 lymph nodes that are positive, sometimes radiation can substitute for having a full dissection. But sometimes you need to have a full dissection. What does that mean? Well, it means a little bit longer recovery time. It means you need to take care of that arm in special ways, like avoid blood draws and blood pressures and gardening without gloves. It means you're a little bit more at risk of having swelling of that arm, but those decisions will be individualized when you see your surgeon and your doctors. Sonoma, California. I was told that the benefit of post-mastectomy radiation is a 3 to 5% improvement in survival, and that the risk of non-cancer related death or illness as a result of radiation is 1% or less. Sorry, this is a long question. I'm at a loss whether it's necessary since post-mastectomy radiation is relatively new. Post-mastectomy radiation is, well, relatively new based on the appearance of man on Earth. You're right, it's extremely new. But it's actually been around for decades and decades, and we have a lot of studies on who needs post-mastectomy radiation, who we're not sure about, and who absolutely doesn't need post-mastectomy radiation. It not only depends on what they find at the time of surgery, some of it depends on the age and the clinical situation. So even though in this particular case, the benefit of post-mastectomy radiation may only be 3 to 5%, in other patients, it can be much, much greater. So it's too hard to generalize the answer to that question on a program like this. That is really something that should be discussed with your doctor about your situation so you can pick the right thing for you. So other questions. Do radiation oncologists do second opinions? Absolutely. I did 2 today. Usually they're very happy to give second opinions, and they want you to go to the doctor where you feel the most comfortable and with whom you feel the most comfortable so you get the right treatment for you. What kind of follow-up should I expect? In general, after radiation therapy, you're seen within a month to 6 weeks to make sure that the skin, the redness has healed. And then one of your oncology team will usually see you every 3 to 4 months for 2 years, and then every 6 you're about 5 years out. Now, it may be a little more often than that depending on the clinical situation, but that's a generalization to when the follow-up is. Now, not everybody on your team may follow you for 5 years. You may not be seeing your surgical oncologist or medical radiation oncologist who would all be doing very similar things, but at least one of your oncologists will probably follow you unless your primary care doctor, which could be your family doctor, your internist, or OBGYN feels very comfortable doing your follow-up themselves. Some primary care doctors feel very comfortable following cancer patients, and they will work out that with your oncologist, but someone needs to follow your cancer on a regular basis. Is it just my surgeon? Oh, I already answered that question. It was asking how many of my doctors will follow me. Again, it depends on the clinical situation. As a radiation oncologist, I at minimum follow patients until I feel like their radiation side effects have become stable. But if they're not receiving any hormonal therapy, so they're not being followed by a medical oncologist, and their surgical oncologist has released them from care, then I am very happy to follow those patients out till 5 years. Sometimes I follow patients even longer. If I've done a new procedure, something that I've not done before, or they're on a research protocol, then I may follow patients out for many, many years. I have several patients that I've had as my patients now for 8 years, and I'm very happy to see them. But a minimum of 5 years by a minimum of at least one doctor that feels comfortable following you as a cancer patient. And I think that's all the questions that I have for today. So if you have any further questions, I'm probably not hard to find. Thank you for attending today, and I was happy to do this. Again, I'm Dr. Catherine Yashar at the University of California, San Diego.